Go ahead, ma'am.
Good afternoon, everybody, and welcome to today's FB Live session. So, today's topic of discussion is what is new in managing poor ovarian reserve. I'm Dr. Rashmi Niphadkar, consultant in Oasis Fertility, Pune. So, let's start our session today by discussing what actually is poor ovarian reserve, right? So, the term poor ovarian reserve will mean that the number of eggs that you have right now in your ovary are on a decline or they have already declined. Okay, so the actual number of eggs in your ovary are what have gone down compared to your age. Right, so in today's practice, we see this quite commonly all over the world. Ovarian reserve is declining rapidly, as well as in males the number of sperms are also rapidly declining. And there might be various reasons for this. It might be our stressful lifestyle, it might be obesity, it might be the sedentariness that our lifestyle brings, it might be due to smoking, environmental pollution. So there can be a lot of reasons why your ovarian reserve has declined, or rather, why globally we are finding this problem of poor ovarian reserve. Now, there also might be some specific reasons to you why your ovarian reserve has particularly declined. And this might be because of any surgery that you have had before, surgeries for cyst, tumors, endometriotic cyst removals. All of this will strip your ovarian cortex and will reduce the number of eggs that are there in your ovary. You may also have undergone any chemotherapy or any radiotherapy. Now, these therapies will rapidly decline your ovarian reserve. You may have certain medications that impact your reserve. You also may fall into the idiopathic category or the unexpected poor reserve category, or that means that no particular cause has been assigned for your poor ovarian reserve. So, these are various different reasons why your reserve may be less. And one of the most important reason that you have to remember is increase in maternal age. So if you have shifted your fertility behind, or if you have taken some time to come to the doctor and your age is more, so we usually see more than 35 years of age, we see a decline in your ovarian reserve. And if you go beyond 40, this ovarian reserve has gone down quite a bit. So if you come later in your age, for us for fertility, we may see that your ovarian reserve has depleted. That means that the number of eggs that are in your ovary are already less when you come to us. So age is a factor, especially when it comes to females. It is very important to notice that if you come to us at an earlier age, we might be able to help you more. If you come at a later age, you're already in depletion, and of course we'll be able to help you, but it will be a little bit of an uphill task for us as well. So age is one of the important factors for ovarian reserve. Now, once you come to us, how do we detect this ovarian reserve? And there are primarily two ways. One, we do your blood test, and in your blood test we are looking for two markers. One is the FSH, or the follicle stimulating hormone, and second is the AMH, or the anti-Mullerian hormone. So if your FSH levels are between 8 to 12, or if they go beyond rather 12, we know that you are in follicular depletion. Secondly, your AMH, or the anti-Mullerian hormone, that is the hormone that is let off in your bloodstream by the little eggs that are there in your ovary. Now, if this hormone is less, that means the number of eggs in your ovaries are depleted, or you are of poor ovarian reserve. So, if your AMH comes 1.2 or less than that, that is how we know that you are a poor ovarian reserve category. Okay, now if your AMH goes below that, if your AMH is say zero point 0.8 or zero point 0.5, we know that you are in a critical reserve. Your ovaries have depleted, the eggs have depleted quite a bit. So that is how your doctor is going to put you in this category of poor ovarian reserve. Now, there are, once you are being diagnosed as a poor ovarian reserve, there are various ways in which we can help you. But the first thing to remember, as soon as your doctor tells you that your eggs have gone down in number, the first thing to remember and keep in mind is not to waste any more time. Don't say that, oh, I'll come back to you after 4 months, or I'll come back to you after 6 months, because you've got to remember, as time passes, these eggs in your ovaries will always go down in number. They will never go up. Your reserve is never on a up stroke. It is always going to go down. So let's not waste any more time. Okay. uh, of course, can you fall pregnant naturally with a poor ovarian reserve? Yes, there is always a chance. that you will ovulate. There's always a chance that you'll keep relations at the right time, and there's always a chance of natural pregnancy. But statistically, your chances do go down of falling pregnant naturally or even on a monitoring cycle. Now, if you do IUI, will you fall pregnant? Yes, of course, you may fall pregnant. But of course, again, statistically, decreased chance of falling pregnant on a poor ovarian reserve. So, of course, your doctor is going to tell you go for a more aggressive management and go for IVF. Now, we have got different protocols for poor ovarian reserve and some different protocols when your ovarian reserve is in the normal category. And of course, again, some different protocols if you are in a hyper responder or a PCOS like category. Before we start your treatment for IVF, we may also give you a couple of months of pre treatment. So these are just adjuvants that we do give. One is to increase the egg quality, because anyways your number have decreased, so whatever eggs we are going to get, we want them of good quality, because only good quality eggs will translate into good embryos in the end, right? So we want to pump up your quality. So we can use adjuvants like DHEA or dehydroepiandrosterone, or a little bit of testosterone support may also be given prior to your treatment, right? So, and then we can also add in some adjuvants during your IVF cycle. So we have growth hormone injections, we can add in aspirin, we can add in antioxidants like CoQ10, we can also add in DHA during your stimulation cycle. So there are different things that we can do to, one, increase the quality of your egg, improve it, and secondly, also make your eggs responsive to the IVF stimulation. So these are some of the things that we can do for you. Secondly, we can choose different IVF protocols for you that will match your ovarian reserve so that we get a good yield of eggs, right? So we all know what the IVF procedure is. We give you gonadotropin injections to stimulate your eggs. We give you injections for maturity. Once these eggs are mature, you undergo the ovum pickup procedure, wherein we take the eggs out of your body, give them to the lab. In the lab, these eggs are mixed with sperms and embryos are formed outside. Once the embryos are formed, you will have a discussion with us which embryos are good quality, which embryos are to be discarded, and then from there onwards we freeze your eggs. Now once your eggs are frozen, you've got two options. You've got an option of immediately transferring back these eggs into you or embryos into you, and secondly, you also have the option of keeping these embryos preserved intact. So, if you want from that point onwards to defer your pregnancy and your childbearing for any personal reason that you have, you may tell your doctor that, you know what, I want to keep my embryos frozen, and now I'll come back to you whenever my personal issues have settled, or whenever I am free to do that, or whenever I want to approach a pregnancy. And you can come back to us and say, now do a transfer for me, I'm in a good position right now. So you always have this option of freezing your embryos on a long term basis as well. You can come back in 4 months, you can come back in 2 years, whenever you are comfortable. But that way, at the back of your mind, you know that you have kept your options intact, right? Because you already are having poor ovarian reserve. So instead of wasting those eggs that you have, you've made use of them, you've developed embryos, and you've frozen good quality embryos so you can come back to them any point of time. Now, suppose you're unmarried, and suppose you come across your case is of poor ovarian reserve. So, what do? How can we help you in that case? If you don't have a partner, then also we can help you, because you may do oocyte cryopreservation. So, in that cycle, same like the IVF cycle, we stimulate you with gonadotropins. We take your eggs out, and now these eggs, the mature eggs, we try and mature those eggs as much as possible. And these matured eggs are what are frozen in our cryopreservation tanks. And then when you do get a partner, we can thaw them, we can mix sperms, we can form embryos, and then we can transfer them back to you. So it doesn't matter if you're married or unmarried, you can always come to us and take fertility treatments for your better future. Now, what sort of new modalities have come for managing poor ovarian reserve? And these modalities are not scientifically proven. Some of them are still undergoing a process of evaluation. But we do some of these modalities. And the first I'd like to tell you is about ovarian rejuvenation, or ovarian PRP installation, as we like to call it. And this is platelet rich plasma that we put in. So basically, we are going to take your blood, Okay, we are going to process the blood and take out platelets from your blood. Now these platelets are going to be activated by an activator, and these activated platelets, we are going to inject them back into your ovaries. So now what this does is that these platelets are going to give off growth factors, and these growth factors are going to stimulate your follicles into growing more, right? So we have seen in a few cases these your eggs growing more after a PRP procedure. So that's one of the procedures that we can do for you. The second, some centers are doing stem cell therapy, right? So over here what we are doing is we are taking your stem cells out of your bones, your bone marrow. We are isolating specific cell lines, we are cultivating those specific cell lines, and then after all this processing we are putting it back again into your ovary, just like a PRP injection. We are injecting it back into your ovary, and here also we've seen good results with stem cell therapies. And the third is ovarian cortical activation. So this is an interesting procedure. What we do is we take out a part of your ovary, a very small part. Ovarian cortical segment is what is taken out from your ovary. Now this cortex is divided into small parts, and these strips, what we like to call ovarian cortical strips, so we activate them with the help of activators. Once activated, we like to put them back in your ovaries and then do your IVF stimulation. And we have seen a good response with cortical stimulation as well. So these are the three new modalities what can be done in poor ovarian reserve patients. So overall, the takeaway from today's session is that identify first poor ovarian reserve or not. Second, if identified, try and find isolate what reason is it for your poor ovarian reserve, and if that reason can be ended or if that reason can be intervened. If not, go for adjuvant therapy, go for a little aggressive management of your therapy. Do not waste any more time. Do not let your reserves slip even more beyond a certain point. Approach fertility treatment in an aggressive way. Go for IVF stimulation and freeze your embryos or freeze your oocytes as soon as possible. Try and add adjuvants to the cycle. And of course, we have the option of going for ovarian rejuvenation. In the end of all this process also, if there is no yield, suppose if there are no embryos that are formed, then of course the last option is for oocyte donation, and of course that gives great results. So that's it for today in what's new in managing poor ovarian reserve, and we'd love to take questions on this topic, whatever they are. We are also giving you a helpline number, so you can call up, you can ask us about any of your queries. And our centers are in Wakad as well as Kharadi. You can do a direct drop in or take appointments for your consultations as well. So if there are any questions, we'd love to take them. Can you get pregnant with diminished ovarian reserve? Yes, as I said before, you can get pregnant with diminished ovarian reserve. You may want to go trying to find why your ovarian reserve is diminished. And more than why, what is important is once you know that your reserve has declined, do not waste any more time. Approach your fertility doctor, chart out a good plan of action for you. You know what suits your case. What are your partner's problems? If your husband has any sperm issues, you may want to tackle that as well. And as a couple, come together with your doctor, talk about it, chart up a good protocol for you, take adjuvant therapy and act on your diminished ovarian reserve. And yes, you can get pregnant even with diminished ovarian reserve. So that was for that question. What are the symptoms of primary ovarian insufficiency? Okay, great. So primary ovarian insufficiency is when your age is less but your reserve has declined. Okay, so your reserve is declined and your menstrual cycle has gone down, so it's like a premature menopause of sorts, right? So a hypoestrogenic environment is created in primary ovarian insufficiency. Basically the amount of estrogen in your system has gone down, and you will see hypoestrogenic effects as the same as which you see in menopause, right? So you may have mood swings, you may have irritability, you may have a little bit of night sweats. Okay, your menses may have stopped. You may have urinary infections that are more common. You may have spotting after keeping relations because your vaginal walls have become dry, they have become hypoestrogenic. You may also sometimes have a little bit of breast pain. Your bones may become a little brittle, what we like to call as osteoporosis may set in earlier than normal, right? So all of these are different symptoms of primary ovarian insufficiency, and in case you have any of these symptoms, do visit your doctor so that we can help you out with them. And of course, if your fertility is an issue, we can also help you out in that. So that was about primary ovarian insufficiency. Is it possible to increase ovarian reserve? So the answer to that is no. As of now, we do not have any treatment that cures depletion of ovarian eggs. There's nothing that directly improves the number of your eggs. So we cannot do that. We can only act on whatever eggs are there right now in your system, right? And all these neotherapies that I talked about may make a little difference here and there, but I cannot really increase the number of eggs in your ovary directly. We can try and improve the quality of your egg. We can try and improve how those eggs react to our therapy, but we cannot directly increase the number of eggs that are there in the ovary. We have to work with what we get. So no, it is not possible to increase ovarian reserve. And the important takeaway is that as you age, as your age progresses, your ovarian reserve will decline. It's a natural process, so it happens in everybody, but there's no going up in the ovarian reserve. Which IVF protocol is best for low ovarian reserve? Okay, so we have various protocols. We have the antagonist protocol. We have some agonist protocols. So we have the microdose flare protocol. We have the short agonist protocol. So we have these different protocols in place. You know, whenever we find a low ovarian reserve patient, we go for these different protocols rather than the normal cycle, right? So these are the different protocols we can use. We can also do pooling cycles. So basically what is pooling is, in the first cycle we give you a normal dose of gonadotropins, a high dose of gonadotropins rather, and suppose you make a few eggs and a few embryos out of that. We want to pull up the cycle, so we want to increase your yield. So the next cycle also we stimulate you with a little different medications, and with a little lower dose of gonadotropin is used, and then we freeze all the embryos from the second cycle as well. So these are two cycles of stimulation, and then we pool the embryos. So that is why it's called the pooling of embryos. And we freeze all the embryos and then transfer. So these are the different strategies of IVF protocols that we can use for low ovarian reserve. Is there any medication for low ovarian reserve? As I said, no, we cannot act on your ovarian reserve. We cannot, there's no increasing the reserve, but there are adjuvants that we can use to one, keep your ovarian reserve as it is intact, and secondly, to try and improve the quality of your reserve. So that is also very important. It's just not just the number that you have to keep in mind, but the quality of eggs that you produce in an IVF cycle is also really important, because that translates into the quality of the embryos eventually. And you want good quality embryos, because good quality embryos are the ones that are going to implant eventually in you, right? So we have different adjuvants. As I said before, we have DHEA, we have low dose testosterone, you have growth injections, you have aspirin, heparin injections, you have antioxidants that can improve the quality. So CoQ10 can be given. So these are the different adjuvants that you can use for low ovarian reserve. But direct medication will be a no. Any more questions? I'd love to take if there are. Okay. So we have a question: low AMH and adenomyosis problem. Is it possible to conceive by normal treatment or others suggest? So okay. So once you say low AMH, I'd like to know what your AMH level is. Is it critically low, or it is just near the lower margin? Okay. So we'd like to typify even low reserve as just a low reserve or very critically low reserve, right? So now once we know your AMH, second, it would be to take your antral follicular count. So that we do by a transvaginal sonography. And once we match both of them, I'd be in a more position to tell you about what to do, right? But low AMH, you have to keep in mind to be more aggressive in your treatment. Do not waste any more cycles. Approach the fertility doctor and start thinking about aggressive treatment. Now, adenomyosis is another problem. We have to know if the adenomyosis is local or if it's a diffuse uterine enlargement. Okay. Now, where adenomyosis comes into the picture is in implantation. Okay. Low AMH is a ovarian problem. Adenomyosis is a uterine problem. Right. Now, is it possible to conceive by normal treatment? Yes, you may have normal pregnancy as well. Even with low AMH and adenomyosis, people do conceive naturally, but it is important to consult with your doctor, show all the other reports, take a holistic picture on this, and then go a little more aggressively. Think about either IUI or rather think about more of an IVF. So that would be my suggestion. Okay, so that's it for today. And thank you for listening in to us. And you can call on this helpline number directly or also come for direct consultations. Thank you so much. Bye bye.